All right. Do you guys see that?
Yes, we can.
All right, let me start there you go. All right. Well, thank you very much for the invitation. It's 7 o'clock here on the eastern side of the United States. And, it's a early morning for us, but I wanted to thank you very much for the invitation. I know that, all of you guys, practice in the field of critical care, and this is a very important concept for all intensivists to know, specifically treatment interventions and then diagnostic approaches. I could spend an hour here talking about the treatment pathways, the treatment interventions for non-convulsive status epilepticus. But there are guidelines out there that have been published that are based on evidence. And all of us are in tune with that. All of us have developed protocols that follow those guidelines. I am not going to talk about that much of treatment options because they follow very, specific rules, right? You identify the patient in non-convulsive status or seizing. You deploy first agents, such as benzodiazepines very quickly, then second agents, and then third agents. If you cannot really control the seizures in that in a specific amount of time. And all of the interventions for the first, second, and third, tier of interventions, right, are based on primarily some clinical trials and expert opinions. And then when you cannot really control seizures, then you're dealing with something that we call refractory status epilepticus, and there are a couple of esoteric options that you can use. But we're not going to talk about that sort of like pathway. We're going to talk about the concept of identification, pretest probability, which patients are at risk, and how can we now and potentially in the future using newer technology that we can learn as intensivists at the point of care. I remember 30 years ago in my medical school training and then in fellowship training, the concept of ultrasound was sort of like alien, for me, and it was a thing for cardiologists that had performed in ultrasound fellowships. Now, intensivists can perform very well with this technique. For example, you can identify certain patterns of shock, certain patterns of, lung diseases, right, with ultrasound within 5 minutes and at the point of care. And now those machines are more portable. You can actually do ultrasound on your iPhone nowadays, right? If you get this, special probe for it. So EEG is not alien to that sort of like concept, and the technology is evolving into incorporating, for example, algorithms of artificial intelligence. And you will hear more and more about AI and how it absorbs some of the things that we do in medicine, and critical care will not be alien to that, and the specific field will not be alien either. Now, one of my favorite quotes by one of the great gurus in neurocritical care said, you wouldn't handle status epilepticus or somebody critically ill where you suspect seizures with no EEG, because that would be similar to trying to deal with a patient with an acute MI and having no EKG. So that is the concept, right, that we're sort of like starting to make sure people understand. And I know technology is expensive, and in low income, low resource areas, right, this may be an issue, right? But if you're building a program, right, and you have access to capital, if you have access to individuals that can help you with building your program, this is part of the things that you need to sort of like start thinking about. How can we get continuous EEG? And I will show you, right, what's the data on continuous EEG, and are there alternatives now in the market that can replace it? And the answer is yes. And probably in the future, outside of the US, you will see more and more of these AI-based EEG machines, getting used in critical care. All right, I have no disclosures pertinent to this topic. This is the status quo. This is why people don't, um, you know, don't like electroencephalography as part of the armamentarium in the critical care unit. But yeah, it is like the EKG. A couple of electrodes. You have to understand, what they're for, what is the reference, how electricity works, and that sort of thing. And this is just a classic montage that we use for conventional continuous EEGs, the classic 20 10 montage. I want to make sure that you guys are still with me.
Yep.
Okay. So it's a classic 10-20 montage, right, that a technician will deploy on a patient that requires continuous EEG, and it's just a reference of electrode to electrode, right? Right, and then when I look at the EEG on the conventional tracing, any odd numbers, right, are represented from the left hemisphere, and every even number is represented on the right hemisphere. So left and right, right? So, I could see patterns here, and then the next thing that you need to sort of like get acquainted with are what are the rhythms on a normal patient. So this is a normal EEG. And what we see here is just normal patterns, right, of alpha activity, right? We see here, 7 to or 8 to 13 hertz of normal activity. And they have a predominance, right, of that rhythm. You see it here in the posterior, parietal, and occipital areas in both sides, right? This is a PDR. This is a rhythm that is classic in a normal patient, right? When you close your eyes, you will see beta activity, which is more than 13 hertz. So it's like a faster activity. And if you're still awake, you will see that activity. If you're in a coma or you're falling asleep, then you start seeing more slowing, which is probably what you would see here in FP2, F8. This looks slowing here, but it's not slow, but it looks something like that, something like flat, right? And those are the three main rhythms, and then you start thinking about theta, right, which is really less than 4 or 5 hertz, right, really slow stuff. And if you have a patient, right, and in the ICU, you can identify these patterns very easily if you start reading a lot of EEGs. Now we can actually see, right, a disorganized, pattern on the EEG, which is the normal thing. Networks in the brain work independently, and you will see the disorganized pattern of normal activity, alpha activity, right, when you're awake. But when you start seeing synchrony, right, on the EEG patterns, then you start thinking there's a pacemaker now, sort of like kicking in, right? And if you start counting, right, those pacemaker spikes, this is a spike right here. If they are frequent enough, right, in 1 second, and it's usually more than 2 spikes per box, right, then you start thinking about seizures. And if they are consistent, right, like in this case, then this is a seizure, right? And then you can train people, nurses, hey, can you identify this stuff, right? The classic, complaint, from non-physician providers, non-epileptologists is that anything that is fast on the EEG is a seizure, and that's actually the wrong concept. What you see when it's very fast activity on the EEG is usually movement or artifact, right? Because brain neurons don't fire more than 18 hertz. I just told you that's the maximum, activity in the beta activity. Everything above, 15, 18 hertz, right, on EEG tracing is usually artifact or muscle artifact. This is a seizure right here. So you can train, as I said, normal individuals, right, or artificial intelligence boxes, right, that can't recognize these patterns. And this is the new kid on the block right now. We have sort of like seen a development of these newer technologies. Are you guys still with me?
Yes, Doctor, we're here.
Yes, sir.
Okay,
Yes.
great. I'm just checking in and out, making sure that the connection is good. So let's put this back. All right. Newer technologies that have summarized that initial montage, this 10-20 montage. Now we have here these technologies that provide 10 channels, right, of EEG. And then you can actually use technology such as wireless access. You can mount these things on people, right? Within 5 minutes, you can train people like nurses, fellows, right? And non-physician providers how to do this stuff. And these bands can last for up to 48 hours, right? And then you can actually get, what the normal requirement for continuous EEG, the highest yield, 48 hours, increases your yield up to 30% with portable and disposable technology that is plugged in with artificial intelligence. So now we have here, right, the same patient, right, where I'm suspecting a seizure, right, And now I'm seeing, I don't know if the video will play, but I will try to play it. You have here, same thing, left side, even numbers, odd numbers, I'm sorry. And then the right side, we have even numbers. But the difference here is that I don't have now the 10 channels that I showed you before. I just have left and right in in those 10 channels that I just mentioned, right? And now I have 4 channels per each hemisphere, a little bit less. But for what I need this for, I don't need this for epilepsy surgery, right? I'm not trying to localize where the foci of seizures are or, which lobe to resect. No, I want to know if the patient is seizing, yes or no. So if you're training EEG, you can say that yes or no if you know how to read EEGs. But now with this technology, I have now the raw EEG that is summarized, and I started to see some weird stuff here, which I showed you before, the spike and the slow waves, right? And they're sort of like organizing, but not so frequent, right? Now I have artificial intelligence, which is down here, and it's showing me in yellow and reds, right? What is the likelihood of these being a seizure? So the more red the line becomes, then the more the machine starts to interpret this as a seizure, right? Or a non-convulsive seizure. And then if I say, if I take a threshold, for example, 80% of that line being above that 80% threshold as my cutoff for non-convulsive status epilepticus definition, then I could start treatment immediately. I don't need to wait for a neurologist to tell me this stuff, right? So I'm going to show you here in the bottom, we have yellow, red, right? And then finally, right, at the end of the seizure, right, the artificial intelligence starts to pick down that the activity sort of like slows down and becomes green, right? So let's see if it plays. Let me know if you guys could see it. Do you guys see that?
Yeah, we can.
Okay, so I'm seeing here abnormal stuff. I'm seeing delta activity, which is not that fast alpha activity, but I'm starting to see these. Let me stop the recording right now, right there. I'm starting to see these spike and slow waves. These are what we call triphasic waveforms right now. And if they are sharp enough, right, like this guy here or this guy here, and they follow this low wave activity, right, and they are frequent enough in somebody in a coma in an ICU, this is a septic patient, then I'm getting concerned that this patient may be in non-convulsive status and then may need to start therapy. And the therapy, as I said, if you Google non-convulsive status epilepticus, you will see the Neurocritical Care Society consensus on the management of it. You start with benzodiazepines. So lorazepam at a dose of 0.1 milligram per kilogram. The doses are very important, right? Not to get behind, dosing a patient with potential seizure. So you need to learn this, have a cheat sheet or memorize them, right? Then if you don't see the patterns going away with lorazepam, you can repeat the dose, right? Or you can move to the second agent. It's usually fosphenytoin, levetiracetam, valproic acid. All neurologists like me, like, for example, phenobarbital, we see this stuff in people that have a lot of like benzodiazepine-like syndromes like alcohol withdrawal, right? Phenobarbital is a great medication if they are seizing. That's the second. And then the third round is if I continue to see this stuff where the patient is clinically seizing, right? Which, by the way, is very unusual. Very unusual for people to clinically seize for more than 5 minutes. I've never seen anyone seizing by, for 30 minutes as the description that the Harrison's internal medicine description was written 20 years ago, right? That's what now we define status of seizure activity of more than 5 minutes. But as I said, I have never seen anyone seizing for more than 3 minutes. I mean, actively seizing. It has to be something like really weird. But so coming back to this EEG, let's continue with the tracing. You will see that it starts to getting a little worse, those spike and slow waveforms. And this is all point of care. A fellow put this on somebody in a coma with septic shock, right? And there it is. Let me see where the line. Okay, you got the seizure right there. And then you start seeing that after treatment, right? We gave him some lorazepam. Those spike and slow waveforms and the artificial intelligence, waveforms start to normalize. You start seeing this thing disappearing. Then eventually it becomes flat. Right there. So now you know, right? Within 5 minutes, you identify somebody that was potentially seizing. You're not letting this get out of hand. And now you're treating the patient. And the way that I would treat this patient is I will put him on a second agent. I will start levetiracetam or fosphenytoin or valproic acid, whatever I have, and the conventional doses. And if the patient is intubated for the medical reasons that I explained, I will probably keep him on a drip of propofol, right, or Versed for ventilator synchrony. And I would continue the monitoring, and we can do this either with continuous EEG if you have that availability, meaning you will hook up this patient to that conventional 1020, you will monitor the patient. We usually do monitoring for 20, 30 minutes, and we will continue with the treatment. Okay, so this is done here. Let's go to the next slide. All right, so when to do EEGs in the intensive care unit. Now, this is a question that I get all the time, right? Why do we do this? When to do it? And my answer is whenever you think that you're dealing with non-convulsive status epilepticus. That's like a big elephant in the room, right? It's like the same question, right? When do I start antibiotics in somebody when I'm suspecting sepsis? Well, the answer is like immediately, right? It's just like you don't even wait for the blood cultures. You don't even wait for the white count or anything like that. You just need a suspicion. You have somebody, right, that has an organ dysfunction. It could be altered mental status and has a port of entry, an ulcer somewhere, or some pneumonia, or some weird stuff, right? You don't need to wait for anything. You just put the patient on antibiotics. It's the same thing here. We do this to detect seizure activity because most of the times this could be subclinical stuff, intermittent. We want to quantify the seizures. We want to classify the spell if we want to, right? If we consult neurology or epilepsy, we want to see if this is like focal or this is generalized stuff, right? And for some of us, right, in the ICU, this is extremely valuable in hypoxia and ischemia as well, right? In patients with cardiac arrest, we want to make sure that they are not seizing up front, right? Because then, treatment is associated with better outcomes, and I'll show you some data on it. And then to prognosticate, sometimes we cannot treat this stuff, and the thing goes on and on and on, and there's nothing you can do about it, right? And then you have to sort of like start thinking, is this the end, or I need to have a discussion with the family, right? Because I'm not going to be able to treat the status. I have had cases, right, where I'm giving a first round of treatment, it works, then the patient, goes back into status, second round, right, it works, and the third round, right, when the patient comes back, it's usually an anoxic patient, right, I'm just like, listen, I'm not going to treat this stuff anymore, it's the end, it's futile, there's nothing we can do about it, sit down, family discussion, end of life. And that is also the utility of having continuous EEG. Which critically ill patients do we do? Which type of patients, right? As I said, anyone where you are suspecting non-convulsive status, those patients are usually abnormal from the mental status perspective. So any impaired consciousness, right? In patients with brain injury, right? You need to sort of like start thinking about monitoring. And this is a fundamental tool now in our ICU. I work in a neuro ICU, so we do this more than my colleagues in critical care medicine, but they are in tune with this stuff, right? Anyone that they think that is comatose and maybe seizing, they hook up the patient immediately, and we start treatment. This is the common pathway, right? Where we sort of like think about it, we'll hear about it, right? But we don't want to do anything about it. Perhaps we shouldn't, even hear about this stuff, right? And that is a problem because status epilepticus is one of those time-dependent interventions where interventions are associated with better outcomes. So the faster that you treat the patient, the better the outcomes, right? Now, this is the prevalence of seizures, right, in ICU populations. This comes from cohort studies that have been published. Of course, anyone with neurological injury is a higher prevalence or pretest probability, right, of having non-convulsive status. But if you see here, right, among these neurological patients, the ones that have the highest pretest probability are the ones that have epilepsy, right? So somebody with a clinical history of seizures or epilepsy, right, or some seizure disorder in the past, they have the highest ones, right? The lowest ones, right, are these guys here with ischemic stroke. You rarely see patients in status with ischemic stroke. It's very rare. Usually a hemorrhagic conversion is something going wrong, right? And then here, the unexplained comas are the ones that are particularly pertinent for us in the medical ICU, right? Now, depending on the patient population, it varies. As I said, in the neuro ICU, we see more stuff, right? In pediatric ICU is probably the highest, right? But look at this stuff here in the MICU. This was published by a study like in the 1990s, right? MICUs have a lot of non-convulsive status epilepticus compared to the neuro ICUs, right? So, and the reason, right, is this guys, altered mental status, right? These encephalopathies, stupor disorders, right? Patients with sepsis, cardiac arrest, they have some degree of brain injury or sepsis-induced brain dysfunction. That's how I call it. Is actually a risk factor for seizures, right? Sepsis is a risk factor for seizures, right? When I presented this talk first, like 20 years ago, when I was in training, these were my mentors. Phil Dellinger, Sergio Zanotti, and Steve Trisiak, right? I like to I wanted to convince them, right, that we needed to be more aggressive in recognizing status epilepticus in medical populations because as I mentioned before, sepsis is actually a risk factor. You have somebody septic in a comatose state or a stuporous state. That's an organ dysfunction right there, right? You should be able to recognize this and treat. In the cardiac arrest population, right, it's very interesting to see that in patients that are in the classic, so like VFib arrest with very quick return to spontaneous circulation, right? You see that the mortality is lower, right, in those patients that are hypothermic. I mean, we know that, right? Mortality is lower when we, control fever. Now we have to control fever. Hypothermia is sort of like a thing that nobody wants to talk about anymore. But in the era of hypothermia, when we were treating cardiac arrest patients, the mortality, right, in patients that were cool, right, with no seizures was 14% in this particular analysis versus 31% in those that were normal or hypothermic, meaning that they had fever. So the mortality is double actually if you don't control for fever, you adjust for temperature modulation. Now, the point that I want to make here is that if you are in status epilepticus, look at this, the mortality is 100% for both. So if you are gung-ho about cooling and modulating temperature and preventing fever, right, in a post-cardiac arrest patient, if you have that technology available, right, and you're doing the whole thing, right, for 24 hours, and then you're keeping them normothermic for an additional 72, and some of us actually will go up to 7 days, right? But if you let them cease, you're undoing that stuff. You're undoing the protection that cooling or fever prevention has in these patient populations, because fever is just a pretty bad thing for brain injury. So having said that, right, the new concept is recognition and treatment, very quickly, right? So how can we do that nowadays, right? And I know that I'm speaking to, colleagues in Africa, right, where resources are a little bit different to the resources that I have here where I practice, right? But this thing is going to hit you very soon. I mean, I think you're going to be seeing this in the market very soon in Europe and Africa and perhaps Australia and Asia, right? These companies are developing it, and this is one of them. There are a couple of other ones. I don't know if in Europe that there are companies sort of like looking at AI and how to use AI in electroencephalography, but the proposal that we have here at my institution, for example, is that the referring institutions that are like little hubs, right? Before they think about sending somebody in non-convulsive status, they had to perform a quick point of care EEG, right? And we can do this right at the bedside. And the patient's not ceasing, right? The patient can stay in the hospital, right? That's it. You are done. And usually an epileptologist or a neurologist is aiding the critical care physicians in this decision. If they identify seizures, then they send the patient to the big institution, right? And then we can do continuous EEG there. But this is a sample or an example, right, of what you could do with somebody, for example, in a cooling environment, right? Somebody in cardiac arrest, right? You want to do, preliminary, assessment, right? Or you can continue with the assessment with the same technology up to 48 hours. This is what we are primarily doing most of the times. We're sort of like doing point of care EEG, and then if the patient is ceasing, then we transition to continuous EEG. If there is suspicion of seizure activity on the point of care, then we are transitioning them to conventional EEG, and these are read by neurology. So that's an example right there of how you can like devise your protocols. For how long? Another question, right? How long are you going to do continuous EEG? Well, the answer is, up to 48 hours in our protocol, okay? Because that's when you achieve the highest yield. Remember, 24 hours the yield is about 30%. And then finally, after 24 hours, 48 hours, I'm sorry, you're not going to get any more benefit from the technology. So, that's the amount of time that we would be recommending to do continuous EEG. Now, if you are not comatose, right? Perhaps sort of like the same thing, non-comatose patients that usually have a higher yield because you can recognize normal patterns very quickly. But 48 hours is sort of like our cutoff for recommending monitoring. Now, why are we talking about monitoring, point of care, quick assessment, right? Is because, you know, as I mentioned before, this is one of those time-dependent interventions, right? The more that you have burden of seizures, right, the worse the neurological outcomes are going to be. And this has been proven over the last 50 years in vitro, in animal models, in petri dishes, right? When you put neurons and you make them, have seizures, right? Or you have animal models that make them seize, right? When you look at the neurons under the microscope, right? They usually destroy the longer the seizure lasts for, the longer the burden is. So when you translate that into humans, right? You will see expressions of glutamine and all these like mean pathways in the brain that end up with neuronal death through different mechanisms, not just ischemia or cerebral edema, also apoptosis and upregulation of weird genes, right, that end up destroying your neurons. So the duration here, right, the lane diagnosis associated with increased mortality. This comes from bona fide data out there that is old as my practice in medicine, right? And I graduated in 1996, right? And this data has been available for almost 30 years, right? The longer that you have a seizure, right, the longer the higher your mortality is going to be, and with that your morbidity, right? You're going to have more time on the ventilator. You're going to have more complications from it. You're going to have a lot of weaning issues, right? Feeding issues. A lot of stuff goes with that. Um, so, time-dependent intervention, right? If you recognize this very quickly, then you're more likely to succeed in treatment. And as I said, sometimes, very unusually, right? Sometimes you end up with refractory status epilepticus. That's an extremely advanced management sort of like issue. This requires, as I mentioned before, esoteric interventions, weird stuff that you can do in intensive care. I'm talking about drips. With sophistication nowadays, you can actually use ketamine drips for this stuff. You can use many other things, and then eventually, right? You can start thinking even about epilepsy surgery. I have had 2 or 3 cases where we ended up in lobectomies for treatment of non-convulsive status. So in every single brain injury that you see association with status, right, the mortality increases, right? In stroke, in ICH, in traumatic brain injury, this has been sort of like established not only on an epidemiological basis, but also, as I said, an in vitro basis. So when you do microdialysis studies, for example, you will see that glutamate expression is higher. The risk of hypoxia in the brain is higher, right, when patients have seizures. That comes from the traumatic brain injury. I mentioned this before. There are consensus out there, national, international guidelines, right, that sort of like tell you what to do in terms of treatment. But one of the important things about these guidelines, right, is the recommendations about continuous EEG, right? So in North America, right, when we have all these like, very strict, policy guideline following institutions, right, you have to take this into consideration and be serious about this, right? So if a neuroscientific society is telling you that you need to initiate continuous EEG within 15 minutes, right? This is what we actually are trying to do right now. When we're trying to replicate that recommendation, right? And if that's feasible somewhere outside of the US, that's questionable, right? But I'm telling you, right, that the way that the world is moving in terms of technology, this is going to reach far more than the US, right? You'll be able to have portable EEG just as much as portable ventilators or portable EKG machines or portable ultrasound machines, right? You will be able to deploy this very quickly. And if you are serious about brain resuscitation, right, this is something that you need to consider. Now, if you cannot really do this, right, but perhaps, as I mentioned before, right, considering institutions or companies, right, that can help you build a program. the lack of EEG when you're dealing with non-convulsive status of people that are subclinically seizing, right, is unacceptable, right? Because of what I mentioned before, all the association with morbidity and mortality. And, in terms of time, when you're dealing with stroke, for example, you have some time cutoffs or benchmarks too, right? You need to give TPA, you need to get a CAT scan, within 30 minutes. You need to get a physician at the bedside, within 15 minutes. You need to, if you're going to do a thrombectomy, right, you need to thrombolize within 60 minutes. You need to do a thrombectomy, you need to do it within 90 minutes. And all those things sort of like start like the clocks, right? The same things for status, right? So the recommendation, you have to have definitive diagnosis and treatment instituted within 60 minutes of onset. So there is a lot of data out there. I send you the slides, so you can actually dig into this information more closely about the determinants of time in terms of status epilepticus management. Which patients are at higher risk? Of course, the elderly are at higher risk of worse outcomes, right? So those are the ones that you need to sort of like take into consideration when you're treating status epilepticus. Are you going to be aggressive or not? How much aggression you're going to institute in these individuals? I usually have plans of care with families, right? Because I mean, I treat a lot of elderly population with brain injury, right? So, we devise plan of care. So we're gonna do this for, let's say, 7 days, right? And I want to see if the seizures go away, right? And if they don't go away, then we call it quits, sit down, and have like discussions, that sort of thing. So having that in mind helps the management as well. Okay, so one of the messages, right, that I always want to deliver, right, is that the most frequent intervention associated with prolongation of status epilepticus is treatment failure, right? So the only way of knowing if you are actually treating something is with EEG, right? So you will be navigating in the night sky, right, with no instruments. If you decide to treat somebody blindly, right, you can give all the antiepileptics that you want, but if you don't know how they're responding, that is problematic. So these empiric treatments, right, are problematic in my opinion. Now, what is the problem? The problem is, can you get access to this technology, right? And yeah, I get it, right? But even with the technology, right, we continue CEG, in institutions such as my institution, right, we have delays in trying to get this stuff on people's heads, right? So for continuous EEG, even at academic institutions, you can see a delay of up to 48 hours, right? And it's depending on all this stuff. First of all, ordering it, right? Recognizing, ordering, um, the technician that needs to come in and put the patient on, start recording, and then finally the recording needs to go to the person that needs to read them, right? So all this takes time. So, with this in mind, right, we had this problem in our satellites, right? So we decided to do this quality improvement program where we actually deployed AI point of care EEG in the patients that we thought were suspecting of having seizures, right? And we looked this over 2 years with my colleague Adam Green here at Cooper. And we developed our protocol. This is our own protocol. This is not based on anything. This is based on our understanding of the technology, right? We use that artificial intelligence machine, and we declare that for us, a burden of more than 70% of seizure activity on that point of care EEG would be enough to start treating, right? And we were treating with no continuous EEG, with no epileptologist telling us this is critical care driven point of care EEG. We train everyone, fellows, residents, and nurses, and this is what we told them. This is what we're gonna do. If the burden is 10%, we continue observation. If the burden is more than 70% and the patient is intubating on sedation, this is what we're gonna do. And we apply the Neurocritical Care Society guidelines for management. We're gonna give second-line agents, right? Then we will wait. Then we will see what happens. If this is not working, we will continue to do this. And this is our protocol, and it's published. And for those that were not intubated, same thing, right? And then finally, if they end up intubating it, then we will continue with drips. And if the burden was within 10 and 70%, this is what we were gonna do. We were gonna load on agents, not for a status. We're just going to put them on an anti-epileptic and see what happens, right? And then at the end of the day, the observation, up to 1 hour, right, we will make a decision. The patient can stay or the patient needs to go to a higher level of care. And that was our, management. This is what we observed, right? This is where we put conventional, point of care EEG, ICU. We use them also in the emergency department. And these are our diagnoses. So post-cardiac arrest, history of epilepsy, and then that big elephant in the room, the undifferentiated altered mental status. Somebody comes with encephalopathy, you don't know what you're dealing with. In up to 80% of the cases, right, we eliminated that diagnosis, non-convulsive status. So we were able within an hour to say efficiently, this is not it. We're not going to treat it. We're not going to put the patient on propofol. The patient was intubated in the emergency department. He's getting all the propofol, getting weaned, and extubated immediately. He doesn't need to be on any anti-epileptic, which is another problem, right? Is that when you don't know, you end up with these patients on all these sedatives. About 20% of people had significant seizure activity. These people were transferred. And then we identify 6%. Remember I said, this is an unusual diagnosis. But you need to recognize these 6% of patients because those are the ones that need all of the healthcare system, all the treatments, right? So up to 80%, we didn't transfer them. Patients stay in the smaller hospital. Families were happy with that, right? They didn't have to drive to the big city, paying tolls and parking fees and all that stuff that comes with it, right? So they were happy, right? So when we looked at the elimination of transfers, right, we basically double, right, the elimination of transfers. We actually decreased the number of transfers that were coming to our big hospital, right, very efficiently on a scientific base. This was not, arbitrary. And then when we look at the cost of savings, right, the costs that we could calculate, because there are costs that we cannot calculate, as I mentioned before, the family burden, the economic burden to many components of the system, right? We could not quantify those, right? But the ones that we could quantify were, for example, the days, the amount of dollars that were involved in transferring somebody on a ventilator to an intensive care unit. And we ended up saving, about, $6,500, right, for each patient that we didn't transfer, right? That we could quantify, as I said. Now, if you count the amount of patients that you keep, it gives you the amount of savings, right, that you have in a year. And so when you multiply this, for example, for 60 patients, which is the we had 88 patients and 80% were kept, right? So about 60%, 60 patients remain in the hospital, right? When you multiply that by 6, it gives you an astronomical number of dollars, right? That you could tell your administration, hey, listen, we saved $200,000 in a year by not sending these people. That pays for the technology on its own, and you actually can use the 90% of the extra money in doing something, else in quality improvement. So that's how we convince our administration in these small hospitals that we're happy with it. So now they keep the patients, and then they don't need to transfer patients. So when do we monitor? As I mentioned before, somebody that it smells like maybe seizing, right? I show you the pretest probability, which cohorts are more likely to seize. For us, non-comatose patients up to 24 hours, we can actually recommend monitoring. You don't need anything like that. More than that, if they're falling commands, you're done. Comatose patients for 48 hours. If they have signs, perhaps you should continue with continuous EEG and consult with neurology or epilepsy. And the spot EEG, the 30-minute EEG, is really, in our opinion, substandard. All right, I think I am within the time frame for the talk, and I want to know if there are questions. I think you guys asked me to do questions and answers. That is my information right there. If you have any questions that you want to ask me offline, I'll be very happy to do so.
Thank you, Dr. Rincon, for that very great presentation. Lots of new things for us to learn and think about as we go ahead in the ICU. I will, if anyone has any questions, please do feel free to unmute or raise your hand. I will begin the first. I have one question. So we have been talking about continuous EEG as the standard when we manage patients with non-convulsive status. Well, most of the ICUs here in Tanzania, we do not have continuous EEG facilities. The maximum that we could do is the conventional EEG. So what would be your recommendation as to how often should someone do the conventional EEG when they're managing patients with status or suspecting someone having status?
Yeah, so I mean, that's a great question, right? And it goes back to that issue with resources and availability of technology, right? So if that is the best that you have, that conventional EEG, which I assume is probably a spot EEG that usually goes for 30 to 60 minutes, that's your best technology, right? And you have also limited resources to deploy that technology. Let's say you just have one box in one hospital, right? And everyone is fighting for the box. That was the case in one of my institutions here. We only had one box, one technologist, and that box was used with the inpatient EEGs and then the outpatient EEGs, right? So it was sort of like a battle. So you have to triage now your conventional EEG, right? Your spot EEG. So, you know, if you're following triage models, right, then of course the one in the inpatient setting is going to end up with the EEG machine. And I would say I would use that as my tool. I would use it as my point of care EEG, right? If I have, you know, somebody that I'm really convinced because of the pretest probability, right? Somebody that has epilepsy and now has an infection, right? And or had epilepsy and was not taking their medications and the levels are low in admission and they season, you know, in the pre-hospital setting and now they're in a coma, intubated. I would deploy that immediately if I can, right, to try to see if I can recognize status, right? If I recognize status, then, you know, I need to treat, right? And if you're asking me if I cannot keep that continuous EEG machine on board, I would say I would treat, you know, with conventional algorithms. I will start with benzodiazepines. I'll put the patient immediately, right, on a drip, perhaps another benzodiazepine such as midazolam. I don't like to do propofol that much for patients that I know are seizing because propofol is a great anesthetic. You know, it will give you a flat line on the EEG, will take away your seizures, but it's not an antiepileptic. So what that means is that when you stop the propofol and you're not loaded on an antiepileptic, the seizures are going to come back. And that has been demonstrated in clinical trials, not in clinical trials, I'm sorry, in observational studies that have had a head-to-head evaluation of propofol versus Versed. Versed tends to take care of the seizures a little longer. It takes a little bit longer to shut down the seizures, right? And then propofol is immediate, right? But the recurrence is lower on Versed drips, for example, compared to propofol. So that's why I usually tell people, you know, if you're dealing with seizures, if you want to do ventilator synchrony, you use a benzo and keep the propofol for something else. We have a new agent right now, ketamine. I don't know if you guys are using ketamine. If you have ketamine available, that's great. It acts at a different receptor, right? So if you have somebody on benzos already, you gave the normal lorazepam up front, you get the fosfenito in a second agent, right? I like valproic acid a lot, right? Because it's a gunshot, right? It attacks many different receptors and electrolyte channels, right? And you know, if you want to be aggressive, right, that's my first choice. And then, you know, if I'm suspecting with that 30-minute EEG somebody having seizures, I'll put the patient on Versed, right? And I will wait until the next day. Then the next day I will bring my tech back. Hey, can you do another 30-minute EEG on this patient? And then I will use it again, and then I will see. I mean, if that is the only thing that you have available, right, that's probably the way that I would use it, right? Sort of like every 30 minutes, every day. So every 24 hours, you will repeat the assessment, right? And you will see, right? The critical part of that is when you start weaning off all these sedatives, right? Let's say that you say, oh, he's not seizing anymore, right? I achieved something. But when you start weaning the antiepileptics, you may end up in the recurrent phase of seizure. Hopefully not, right? So then you may need to do several assessments in several days, right? If that's the only thing that you have available.
All right. Thank you. Thank you. If anyone has any other questions, please, you're welcome to ask. All right. Okay, I think
Dr. Molidina, sorry, I have a question.
Yes, Dr. Sange, please go ahead.
Yeah, my name is Dr. Ismail Sange. I'm an emergency physician intensivist practicing in Tanzania. I thank you for bringing up an AI technology on EEG. I know it's a very far-fetched for us here, and it's good to know that at least we may think of it. I might have missed the point that you have mentioned on cardiac arrest. How soon we have to do an EEG on a of patients of the cardiac arrest. Because what, on my observation and many observations, post-cardiac arrest patients do come up with so much of status, and which are apparently subclinical seizures. These are non-convulsive seizures. So how would you, in our settings, we do not have EEG on board, or suppose if we had an EEG, I know there might be some EEG finding that tells you that, okay, there is a seizure activity, or maybe there might be some artifacts that can mislead you, that saying that that's not really a seizure. So maybe can you enlighten us on that part,
Yes.
please?
So on the first part of the question, how soon to start conventional EEG on a post-cardiac arrest patient in a coma, right? Because I mean, if you have post-cardiac arrest and you start to wake up, right, and you start following commands, you don't need EEG, you don't need any temperature modulation. You're sort of like basically proving to the healthcare system that you survive cardiac arrest and you probably are not going to have any brain injury. But the problem is in the comatose or stuporous patients, right? The ones that end up on the ventilator in an intensive care unit, and then you're going to do some degree of temperature modulation with fever control or normothermia or even hypothermia. I mean, I don't know what you're using, but so the recommendation is within 60 minutes, all right? Because of what you just said. There are, I mean, the pretest probability of somebody in a coma post-cardiac arrest with anoxia and ischemia of having seizure or ictal patterns, right? Not seizures, maybe ictal patterns. And that is another problem, right? Is that ictal patterns, right? They are these weird EEG waveforms, right? That mean brain injury. Those are the tips of the iceberg that I call, right? The patient is not seizing, right? But you have a signature there that brain has sustained some degree of brain injury and has the potential to develop seizures, right? So what to do within 60 minutes if you can, all right? And to answer the question, right, if you just have a spot EEG, how can you triage this? So you will have to figure it out, a triage mechanism for that only box that you have in the hospital. You can do spot EEGs every 6 hours or every 8 hours. I mean, I don't know, what to tell you, right? But you're right. If you have somebody seizing post-cardiac arrest, the likelihood of that outcome is going to be poor if you don't treat the seizure activity, right? And you basically are like not doing anything, right? If you are cooling the patient and not treating the seizures, you are not doing anything at all. So you need to identify those patterns. And then there's some patterns also on the EEG that tell you about prognostication and mortality, right? The myoclonic status epilepticus in the past, in the 1990, the American Academy of Neurology had a guideline, right, where it says if you are myoclonus after post-cardiac arrest from hypoxia ischemia, your outcome is vegetative state, right? They changed that, right? That's no longer the thought. You can treat myoclonic status, and if you're effective, the outcome is going to be better than vegetative state. So, and then there are patterns on the EEG that tell you perhaps you should not do anything at all, right? If you have a flat line, if you have, weird patterns, alpha comas, right? You have somebody in a coma and it's an alpha rhythm, right? You have burst suppression patterns, right? That are these like very fast bursts or spike and slow waves, usually 1.5 to 2.5 hertz, and then patterns of flatline, right? That's usually problematic also, and it tells you a lot of prognosis. And those are the ones where I am actually start sitting with the family early on. And I know that it may not resonate very well with some of my colleagues, right? Because if you do cooling, right, and then you treat status, you want to wait a little bit longer, but that's okay. And that's why I said the trials of intervention, designing a trial with the family and in mind, right? We're going to do this for 3 days, right? If we continue to see these patterns, that usually means something obnoxious, right? The patient's going to die, not going to do well. I would basically stop advanced life support, right? So those are the things that you need to sort of like think about in post-cardiac arrest patients, right? One, if you could do EEGs up front, and if you're not seizing, that's great. You need to repeat it down the road. If you are seizing, you need to treat, see what happens with the treatment. If you only have 30 minutes or 60 minutes, hopefully you will be able to see that you are treating somebody, put him on a Versa drip, for 24 hours, then monitor again the next day. If the patient is not seizing, then you are pretty pretty good, right? Hopefully you have loaded the patient on an antiepileptic. And then you continue to do these serial assessments, such as like point of care ultrasound, right? You do assessments at the bedside, trying to make decisions. And then at the third day, which is when everything is supposed to stop in terms of cooling for these cardiac arrest patients, right? If the patient is not seizing anymore, you call it quits, and then you start weaning and see if the patient wakes up. And then you do your assessment for neuroprognostication the best that you can. But the EEG is extremely important for those two reasons, right? Recognizing it and the neuroprognostic factors that you can derive from it.
Dr. Rincon?
Yes.
Dr. Malindina, may I?
Yes,
This is Dr.
Yes, go
Kabani.
ahead.
Yeah. This is Dr. Kabani. I'm intensivist in Houston, and I was interested in your comment about propofol, whether or not to use it in post-cardiac arrest patients or patients that we are trying to manage the seizures for. Because I know
Yes.
there's been some controversy about the pro-convulsant versus the anti-epileptic effect of propofol. I just wanted to know your thoughts and where we are
Yeah.
on this thinking.
Yes. So I mentioned that I am not a fan of propofol in status epilepticus management, right? Because as I mentioned before, it's an anesthetic. It shuts down the neurons and the brain very quickly and efficiently, right? I mean, that's why you use it for sedation. You put somebody on propofol and you look at the EEGs, they're going to go flat, right? But, it's not an antiepileptic, so it doesn't have any antiepileptic activity, meaning the moment that you stop the propofol, that GABAergic effect goes away immediately. The metabolism is very quick. And there may not be enough time for those neurons, right, to sort of like get disinhibited, right? As much as the normal antiepileptics like benzodiazepines that have a longer period of time, right? So those linger more time in the system, and by in doing so, they stimulate the GABA receptor more, more, and then it disinhibits the neurons more efficiently. The same thing for the other antiepileptics, right? They have different mechanisms of action that activate, or deactivate certain, receptor channels, and in the case of ketamine, right, it acts at a different receptor as well. So, but I'm not a fan because there is a study by Klassen that compare Versed at the highest dose for the management of status, which was actually a dose of 3 milligrams per kilogram. That's a humongous dose of Versed for management of status. We don't do that anymore, by the way. When we hit 1 milligram, we're usually converting the patient to ketamine, to avoid the volume overload that comes with those those Versed infusions. But when he compared those Versed patients at that very high dose to propofol patients that were being treated for status, he saw that yes, the management is better with propofol. The seizures disappear faster, but they recur in a higher proportion in the patients of propofol because it lacks of this anti-epileptic activity. So you can make the argument, right, that if you load a patient on enough anti-epileptic, you could still use propofol and then see what happens as long as you have continuous EEG to see that there's no recurrence when you start weaning the propofol. For cardiac arrest patients, right, that I am submitting to temperature modulation, it could be a mild degree of hypothermia, such as 36, or even hypothermia. Sometimes we do hypothermia in patients that are young, that have a lot of cerebral edema. We bring them down to 33. Some of us would do that, right? What I've seen with propofol infusions is that the metabolism gets really out of control, and the metabolism it's not as it's not normal anymore. So you tend to have more propofol circulating, and I have seen a couple of cases of propofol infusion syndrome when I'm doing heavy duty sedation status in patients that are hypothermic. So that's why I'm not a fan of propofol in this particular setting, cardiac arrest, post cardiac arrest with status. And if that's the only thing that you have, well, that's the only thing that you might need to use. But if you're using propofol for management of status, right, because you want to see the seizures going away, make sure that you are loading the patient on the right doses of conventional antiepileptics, because that's the thing that is going to prevent the recurrence.
Thank you so much.
You're welcome.
Thank you, Dr. Noor. Thank you, Dr. Fred, for that answer. I think we will stop here for the sake of time and let Dr. Fred get back to work. So we all will thank you, Dr. Fred, for that early morning webinar from your car. And we're happy that you could volunteer and we share your expertise with us. Yeah.
Thank you very much for the invitation. I'm on my way to California, so I'm taking a flight right now. So thanks a lot.
Yeah, thank you very much. And thank you all for joining. If you guys have any feedback for this session, for the upcoming sessions, anything you'd like to hear about, please, you can email me. You have my email. And Dr. Fred, thank you very much.
You're welcome. Have a good day.
Thank you. Thank you all for coming.